Recent trends have suggested and shown shift of predominance from men to similar occurrence in both men and women. Despite a modest decline in mortality, hospitalizations, and office visits, PUD remains one of the most common GI diseases, resulting in impaired quality of life, work loss, and high-cost medical care. It's thought and known that in most cases, PUD arises in the presence of acid in pepsin when H. pylori, NSAIDs, and other cofactors that disrupts the normal mucosal defense mechanism. H. pylori bacteria. H. pylori is a spiral-shaped gram-negative, microaerophilic bacterium that resides between the mucus layer and surface epithelial cells in the stomach, or any location where gastric epithelium is found. When an individual infected with H. pylori infection, it was stated that he will be affected with chronic gastritis, which causally linked or eventually developed to peptic ulcer disease. The prevalence of H. pylori varies by geographic location, socioeconomic conditions, ethnicity, age. An utmost prevalence of H. pylori infection is seen in the developing countries when compared to industrialized countries. H. pylori produces a massive amount of urease, which then hydrolyzes urea in the gastric secretions to carbon dioxide and ammonia. And this creates a neutral environment for the bacteria to sustain and infect, as it's considered to be pH sensitive. Yeah, it's right. H. pylori invasion produces ulcers. But how? Firstly, the mucosal injury, a significant event, occurs as the bacteria releases enzymes that are destructive in nature, namely, urease, lipases, and proteases. Adherence also plays a prominent role, in which H. pylori gets attached to the gastric epithelial cells by means of adherence pedestals. Lipases and proteases degrade gastric mucus. Ammonia produced due to urease attack easily uptaken to gastric epithelium, that even cause a higher toxic event to gastric epithelial cells. In response to invaded bacteria, host immune system produces an inflammatory response through sequential events, which results in the destruction of epithelial cells by cell-mediated immunity mechanisms or by phagocytosis. As stated previously, NSAIDs also shows a significant impact in developing peptic ulcers when compared to H. pylori. The two prominent mechanisms that NSAIDs can develop ulcers are direct or topical irritation of the gastric epithelium and systemic inhibition of endogenous mucosal prostaglandin synthesis. The acidic properties of most of the NSAIDs also contribute to the disease in developing topical injury of gastric tract. Aspirin is one of the agents that have a greater efficacy in causing topical irritant effect. Cyclooxygenase 1 or COX-1, and cyclooxygenase 2 or COX-2. These are isoforms of COX, in which COX-1 is found in stomach, kidney, intestine, and platelets. Whereas, COX-2 is undetectable in normal physiologic conditions, meaning that its presence is observed during acute inflammation and arthritis. COX-1 produces prostaglandin, an important inflammatory mediator, serves in gastric protection, regulate physiologic processes such as GI mucosal integrity, platelet homeostasis, and renal function. COX-2 also produces prostaglandin that is involved in fever, pain, and inflammation. Okay, that's a pretty tricky movie, right? But what do NSAIDs perform in the act? NSAIDs constitutes as two forms, selective and non-selective forms. The non-selective forms inhibit both COX-1 and COX-2. So, as stated before, inhibiting COX-1 could produce a reduced or a declined effect of prostaglandins, eventually exposing the gastric layer or gastric mucosa to a higher acid output. But in selective forms, drugs such as celecoxib inhibits only COX-2, without any significant effect on prostaglandins derived from COX-1.